Hello, everyone. My name is Chase, and I'll be presenting organizational issues directly involved with upright spine imaging exams in the emergency department, or ED for short. In upright spine imaging studies, the patient is required to stand up, unassisted, and hold still for 5 to 10 minutes while the tech takes the images. This is often a very painful exam for the patient, as this is the first time the patient has stood since injuring their spine. I will be reviewing some of the issues of our current workflow and how we can strive to improve ourselves for safer, more effective, collaborative patient care. Let's begin with some background. This issue takes place in ED radiology and involves three key players: the registered nurses, or RNs, the ordering providers, and the X-ray technologists. From start to finish, upright spine imaging exams take the most time to coordinate in terms of safety and exam specificity. We have to coordinate care with the nursing staff for the patient, ensure we have the correct exam for the provider, and make sure that the patient has been safely upright to our protocol standards. The issue that we are experiencing is a lack of communication and an unclear workflow for these exams. It's causing serious safety issues for patients and staff, and an organizational overhaul is long overdue. The issue is extremely well documented. Some of the symptoms and evidence that we are able to see is that every time a staff member or a patient experiences an adverse event directly affecting patient care, we file what is called a patient safety net, or PSN. The PSN is then reviewed by a supervisor who then follows up on the event or logs it as a paper trail for plans moving forward. As technologists, we have submitted numerous PSNs regarding upright spine orders. Exams that were ordered incorrectly led to patient falls, staff injuries, or unsafe conditions were all reported. Little has been done to rectify the issue, despite the complaints coming from outside the department as well. Nursing is upset that they have to stand or sit patients up who may have complex injuries, or their exams take too long and the patient cannot tolerate the pain. Ordering providers have complained that the exam is not completed in a timely manner, or that they were unaware the study had to be ordered a certain way. The exam must be ordered with the correct information, the patient must safely be stood up or sat up, and all the teams have to be on the same page. Here are some of the consequences created by the lack of a clear process. Mistrust of orders. When an order appears on our queue, we have been taught to question everything and always double check that everything we need is accurate. The location of the injury, whether or not the order specifies upright, and if the patient has any other injuries, all have to be confirmed before the patient is brought over for imaging. If we don't have enough information or the order seems wrong, we have to message the order provider correctly and hope that they are available to answer. If exams are completed with insufficient information, for example, the spine is not specified as upright, so we perform it supine, the exam has to be repeated. This is a double exposure to the patient and a double charge to their hospital bill. If providers are unable to be reached through various forms of communication, the exam is delayed until all the information is known. Providers can be directly messaged through a secure chat, paged, or found in person in the ED, though many times providers are busy and can't be reached, or the ordering provider listed as the wrong person. The tech ends up searching all over creation to clarify orders, and the exam gets pushed to the back of our list. This creates frustration with the team who may want the images for surgery planning, admission to the hospital, or discharge. There are many potential causes for these issues, but the most prominent cause is the lack of education regarding spine imaging protocol. There is a significant pressure to have radiology coordinate everything from the ground up, and providers and nursing staff can be confused or unaware of their role in the process. Also, radiology is never the first to get a patient upright, and this is not common knowledge in the ED. Providers are frustrated that it must be them alone, but it is for the patient's safety. It protects us and the patient in the event of a spinal injury, and we do not have access to their spine clearance from their provider. The provider must sit the patient upright first, and then the nursing staff is responsible for safely standing the patient at bedside to confirm that they are stable for imaging. This prevents falls and ensures that if there's any intervention needed, they have the proper care straight away. Another cause for incorrect orders is improper assessment. Neurology consults who have not physically seen the patient may submit an order for a standing spine without knowing that the patient has 2 broken legs. Obviously, the patient cannot tolerate the exam, and the order should be followed up with the provider. Since everyone's name is attached to everything we do in the hospital, there's also a culture of blame that is created when a process isn't progressing as it should. In radiology, we do a lot of follow-up and double-checking of orders, and it has created some issues with providers thinking we're refusing or questioning their orders. In the department, we have a large print book of our imaging protocols. This book dictates how exams are coordinated and depending on injury location, number of views, and if they require others present, like attendings or a radiologist. The protocols were created by the radiologist and keep our exams within our limits according to safety and resources. They also exist to back us up when providers question why we can't perform an exam for a certain reason, and we can reference them when necessary. They ensure our safety and protect us from performing out of our scope. They also protect patients from unnecessary exams and ensure that we aren't manipulating certain spine injuries without providers present. While the specifics are our responsibility to coordinate, the ED encounters these exams often enough that longtime employees are aware of the process. However, as a teaching hospital with lots of rotating staff and now with a lot of travelers, we have more people than ever who are unfamiliar with the standard practices. These protocols are viewable online as well, but they are very hard to find. Additionally, the order must contain the proper information in the reason for exam section. We have access to their chart for general information, but need to know exactly what the films are for. The location of the injury, for example, L3, which means the third of your lumbar spine, T1, or so forth, needs to be specified so we know we have the right exam, and uprights need to be in the comments so we know not to perform the study as supine. Uprights are needed to assess stability after injury is confirmed, whereas a general study supine can be done just to confirm an injury. In a hurry to submit the order, the provider may not specify the reason or simply put T-spine fracture or motor vehicle collision. This is where the clarification hunt begins. On the other hand, the order may come from a consulting doctor who knows only about the spine injury and may be unaware that the patient cannot safely tolerate this exam. Usually this comes from neurology. They are notoriously hard to get a hold of and oftentimes make the emergency department stand their patients for them, despite knowing that they could be liable for an injury if the patient falls. It usually comes down to the argument of, I have too many patients, someone else will have to do it, and we have to track somebody down. This also circles back to the culture of blame. A lot of these problems stem from unclear roles after the order has been submitted. As previously mentioned, radiology is never the first to sit a patient upright. The tech role is ensuring that the exam is correct, it progresses safely, and the images are diagnostic. The patient's stability and pain management need to be assessed and communicated to the technologist via the RN after the tech makes them aware of the order. If they're comfortable and the patient's spine is cleared by the provider, they are required to complete the stand test at bedside, which is just as it sounds. Stand the patient. If they can tolerate it, let the tech know so we can shoot it while they are able to do so. These exams can be time sensitive because meds can wear off and the patient may not be able to tolerate the pain. In this case, the patient cannot stand and we may have to try over several hours to complete the exam. Some orders even take days if the patient is admitted to the floor. Interactional difficulties, or in these interpersonal conflicts, are created because the ED is dependent on reciprocal interdependence. This means that we need others to accomplish tasks, give us information, complete tasks for them, or etc. in order to function and contribute to the goal of patient care. If those we require outputs from are not aware of their roles in our workflow, it creates an imbalance that stops all the contributors in the system. In this case, the end product is the exam is not done. For example, if the exam is not done, the provider may become frustrated and question why. We have to explain we are waiting for someone to sit them up. They explain they can be sat up. We explain that we cannot be the first to sit them up. We ask the RN who is not comfortable and thinks that the patient will not be able to tolerate it. If the provider then becomes agitated and walks over to sit the patient upright themselves. This whole interaction could have been avoided if the provider was aware of their role and coordinated with the RN from the get-go. It always becomes a personal affront when really it's their sole role in the process. Everybody's frustrated and the provider is upset that they have been inconvenienced. A little more on reciprocal interdependence. As previously mentioned, this makes the ED go round. Availability is huge, but conciseness and accuracy are also important. Our jobs are in a fast-paced and changing environment, and efficient information is the best way to communicate to providers who are used to direct information-only phrasing. Nursing staff are actually taught to speak this way using an acronym, SBAR, S-B-A-R. This stands for Situation, Background, Assessment, and Recommendation. I've started using this when talking to providers in secure chats, and it's been a huge help. This is a wonderfully concise model that uses need-to-know information only and helps structure the interaction. For example, I have Jane Doe from bed 22. She has an L1 fracture and cannot stand for her exam. Can we change this exam to a seated TL junction view in order to get the most diagnostic information? This contains no filler, only pertinent information, and asks a question, and recommends a change. In secure chats with busy providers or on the go in person, this ensures the response is easy and the conversation is brief. The issue is significant to both the staff and the organization as a whole. The organization may be vulnerable to litigation and medical malpractice if the patient is injured during the exam at the physician's request. The organization may also experience more rapid turnover if processes like these are continually stressing and burning out the staff. Staff want to feel supported and safe. The example that this continued avoidance set is that the management doesn't care enough to change it and that they're not listening to their staff feedback over the issue. As for patients and staff directly involved in the process, we've had techs who have all but held patients upright during the exposure or caught a patient as they fell. If the injury is severe enough, LNI could be involved for the staff's behalf. On the patient side, even if they tolerated the exam, if they have to return for a second exam after an order was completed incorrectly, like supine instead of upright, that's a double charge to the hospital bill, and they have to endure the pain of the exam twice. This issue involves different groups who all have strong opinions that their side is not at fault. And they're correct. The process is flawed. In order to open the lines of communication and standardize the process, I think the head of the ED nursing staff, the ED attendings, and the radiology leads should be present to renegotiate the roles and the sequence of events for upright spine imaging. I also think that a mediator present from human resources would be a good idea. Just to take notes and keep everyone accountable for their words. I think Lewin's change model would be the most appropriate here. In the meeting, that will act as an unfreezing period where all the PSNs and staff feedback can be brought into the open, the issue established, and the planning change can occur. The next step, the move stage, will be inputs from all three departments regarding the current spine protocol, reiteration of roles and reminders, and how each department can best communicate the correct questions to the correct party. The new upright spine protocol with roles assigned can be emailed out to each of the head staff, so all ER nurses, all ER residents, and all technologist staff. This will happen at once and will be ground zero for the refreezing period. Now each department has a source for the protocol that they agreed on, and they can answer questions posed to them by their own staff. To monitor the effectiveness of the change, we can look to see if there's a reduction in PSNs related to upright spine imaging, check in with staff on the effectiveness of the new protocol, and tweak it as needed. This slide is a really great example of the cycle of change through Lewin's model, beginning with employee involvement in change, this proposal, knowledge sharing, meeting with the heads of the departments, leadership, the standardized protocol being built, implementation of the change, the email sent out to all staff, organizational change, the new protocols being followed and reinforced, and the feedback is given to heads regarding the effectiveness of the change. This feedback could start a whole new change process after enough information is gathered, and the cycle can begin again. Some evidence of the effectiveness of the change can be observed by an increase in the accuracy of orders, patients being stood or set up safely without delay or confusion of roles, exams completed in a more timely manner, patient condition is properly assessed and prepared for the exam, and communication is facilitated and appropriate in the setting of newly established roles. In conclusion, this intervention to the organization represents a form of total quality management, where a group of people is brought together to solve a problem. With the assistance of each department's background, combined knowledge, and an agreed upon standard of practice, the solution can be reached and the change enacted. This is not an impossible task, just one that takes patience, strategy, and teamwork. Thank you.